Okay, so we were discussing about type 2 diabetes mellitus. Now I am going to discuss about its morphology. Okay, morphology of diabetes and its complications. Okay, morphology we are going to discuss now one by one. Okay, is any query related to this part of diabetes, pathogenesis of diabetes? What is insulin and what happens due to insulin resistance? That part we discussed. Okay, let me allow all the students to enter. Okay, this is again in this slide. It is pathophysiology is described of diabetes 2, diabetes type 2 diabetes. That is here the carbohydrate diet, digestive decreased digestive enzymes, the glucose is get in the circulation. Okay, it is due to accelerated gastric emptying. So whenever glucose enters into your system, it will get released by various in the circulation to various organs. Okay, so here the cells they are defective. The cells they are defective. So this glucose excess of it is related. It reaches to various organs. Glucose. Okay, it could not get stored due to insulin resistance because defective beta cell secretions is there, and resistance of insulin is also there. So both of these two things causes this uh, this glucose enters into that particular system. There is excessive lipolysis due to this increased glucose molecules, increased uptake of glucose molecules. Okay, so excess glucose production by the liver, it is also generated due to this reduced glucose uptake. Okay, so all these things they are related with the resistance to the action of insulin. Okay, now we will go towards morphology. That is what happens in the pancreas due to this diabetes 2, type 2 diabetes mellitus. What happens to the pancreas? There is first effect on pancreas is reduction in the number and size of islets. The size and the number of the cells, islet cells, they get decreases. The second thing that happened is leukolytic infiltration of islets. Then there is beta cell degranulation occurs. Beta cell degranulation occurs. In type 2 diabetes mellitus, there may be also reduction of the islet cell mass. The mass of islet cells also decreases. Next, what happens with the pancreas is amyloid replacement of islets in type 2 diabetes mellitus. It is related with type 2 diabetes mellitus. This beta cell degranulation and decrease of islet cell mass causes replacement, amyloid replacement of islets. Then next, which happens is hyaline arteriosclerosis in various organs. Then diabetic microangiopathy, diabetic nephropathy, and diabetic neuropathy. So these are the morphological, this morphology of diabetes mellitus that we are going to discuss one by one. So with the pancreas, what happens with the pancreas? That is, in the pancreas, the lesions in the pancreas, they are very much inconstant. Okay, so the distinctive this changes, they are more commonly associated with type 1 than with the type 2 diabetes mellitus. Okay, the first is reduction in the number and size of islets. This is most commonly seen in type 1 diabetes mellitus. Okay, particularly with this autoimmune conditions. No, they are also involved with this particular or genetic susceptibility, autoimmunity. They are involved in this type 1 diabetes mellitus, and so there is destruction and the reduction in the size and the number of islets. It is commonly seen in the type 1 diabetes mellitus. Okay. Then leukocytic infiltration of islets. We call it as insulitis. We call it as insulitis. That is, it is principally composed of T lymphocytes, which similar to that in the autoimmune diabetes mellitus. Okay. So, autoimmune diabetes mellitus, there is this autoimmune, that is type 1 diabetes mellitus. Recollecting now, everyone? So this here the insulitis to this T lymphocytes. Okay. So this again the distribution of this insulitis, it is uneven. It is not a very much evenly this insulitis occurs, but it is patchy. It is uneven. Then there may be eosinophilic infiltrate also may found. Okay, particularly in the diabetic infants who fails to survive to the immediate postnatal period. Okay, so in that case, that is so much severe condition, this eosinophilic infiltrations also may found. Okay, now there are long-term complications of diabetes mellitus. That is, we call it as microangiopathy. That is cerebral vascular infarcts and hemorrhages. We can see, we call it as microangiopathy. Then retinopathy. It is very much common with chronic diabetic patients which are having uncontrolled glucose levels. Okay, so retinopathy, we call it as diabetic retinopathy. Then cataract, it is also very much common. Then glaucoma, it is also common with this diabetes mellitus. Then next complication is hypertension due to atherosclerotic changes. Okay, this free fatty acid metabolism just we discussed. So this because of this free fatty metabolism, free fatty acids, they remain circulates, and the process of atherosclerosis is morely, it is go hand in hand with this diabetes mellitus. This hypertension and diabetes mellitus always go hand in hand, and this is because of early degenerative process of arterial wall or atherosclerotic changes. Okay, both of these things, they are related with diabetes mellitus. Then myocardial infarction, it is also common with this diabetes mellitus. Atherosclerosis is common. Then with pancreas, there is islet cell loss, insulitis in case of type 1, and amyloidosis in type 2. See, this insulitis, it is very much common with this type 1 diabetes mellitus. Okay. Then again we will go below, that is towards kidney. There is nephrosclerosis, glomerulonephrosclerosis, then arteriosclerosis, and pyelonephritis. These are the very much common complications with related with the kidneys. Okay. Then there is peripheral neuropathy. Okay, peripheral neuropathy is very much common with this diabetes, chronic diabetes mellitus. That is, what is neuropathy? Burning, tingling of this peripheral nerves, constant burning, tingling in the peripheral nerves. Okay, then there is peripheral vascular atherosclerosis. Peripheral vascular atherosclerosis, which gives rise to gangrene, and later more there is infections. This gangrene may go in complications with the infections. Okay, so these are all the long term complications of diabetes mellitus. Okay, now this the next uh, part we are going to discuss, that is, here again in the slide you can see with type 2 diabetes mellitus, the cause is too much of food with too much of animal fat. Okay, then not enough exercise, then uh, genes, genetic involvement is there, this inherited genetic predispositions from the parents that make you hungry, and this hungriness, it is also related with high carbohydrate diet. Okay, whenever you take more carbs or more carbohydrates, you feel hungry uh, with little intervals. Okay, so this all things causes overweight. Okay, needs extra insulin as body become resistant, and this another set of genes which causes insulin resistance. Okay, so this all factor gives rise to this overweight, and this will increases the insulin resistance. Okay, which gives rise to this again, it is what are the effects of these things. So the effects of these things, they are the deposition of fat in the pancreas and cause more damage, and again the effect of the other genetic predispositions which destroy the isolate cells. Okay, so they could not get could not able to secrete insulin in proper amount, they get degenerated and cannot make enough amount of insulin. So this result in the body needs more insulin but cannot produce, which gives rise to type 2 diabetes mellitus. Okay. So again, you can figure out this particular slide to assess more things. Okay. So we discussed today with diabetes type 2. Okay. So that gives rise to all the complications along with etiopathogenesis and what are the complications. So the main effect of this type 1 diabetes mellitus is beta cell destruction, insulin deficiency. Type 1 diabetes mellitus. But type 2 diabetes mellitus, there is insulin present, but there is disturbance in the receptor, or the second part is insulin resistance. So these two parts, they are related with type 2 diabetes mellitus. Okay. So now what are the complications of type 1 diabetes mellitus? Again, it is related with polyphagia, then ketoacidosis and hyperglycemia, which leading into diabetic coma. Okay, this ketoacidosis will gives rise to diabetic coma, and hyperglycemia, it acts on kidneys, which gives rise to ketonuria, glycosuria, which again gives rise to polyuria, that is increase in amount of urine secretions. We call it as polyuria, which gives rise to volume depletion in the body, that is decreased volume in the body, volume of fluid in the body, which gives rise to polydipsia. Okay, so polyphagia. This polyphagia is due to insulin deficiency, which leads to decreased tissues. Which gives rise to decreased tissue utilization, glucose utilization, which again affect on the adipose tissue. They increase the lipolysis, that is, there is release of free fatty acid. Just we discussed about this free fatty acids, and this gives rise to polyphagia. Then this decreased tissue glucose utilization again acts on the muscles, which increases the protein catabolism, that is mainly amino acids, which causes this glyconeogenesis. It causes glyconeogenesis. Okay. So it is also related with glucagon excess. In case of insulin deficiency, glucagon, because it is a counteracting hormones, no, both insulin and glucagon. So whenever there is deficiency of glucose, glucagon in excess releases in excess amount, and which causes glyconeogenesis. So there is more production of glucose by the liver. It releases into, it causes hyperglycemia. Okay. And the other cause of hyperglycemia is decreased tissue glucose utilization. Okay, decreased tissue glucose utilization. Glucose remains in the blood, which again causes hyperglycemia. So what are the two things related with hyperglycemia? The first is increased gluconeogenesis, and that is by the liver. More amount of glucose start forming by the liver because of glucagon excess. Understanding? Whenever the glucagon is in excess, gluconeogenesis, it get activated, okay, by the liver, and there is more production of glucose, which remains in the blood, causes hyperglycemia. Again, the other byproduct of gluconeogenesis is ketogenesis. The second thing occurs with the liver is ketogenesis. Why ketogenesis? Because of increased free fatty acids by the adipose tissue, that is due to increased lipolysis. This increased lipolysis causes this free fatty acid generation, and which initiates the ketogenesis by the liver, which gives rise to ketoacidosis, release of ketone bodies. Understanding? These are all the morphological parts due to this type 1 diabetes mellitus or type 2 diabetes mellitus. Okay. So whenever there is insulin deficiency or insufficiency, this all these things, they are interrelated. This lipolysis by the adipose tissue causes release of free fatty acids, which gives rise to polyphagia. Then it activates ketogenesis by the liver. Then again polyphagia increases gluconeogenesis. Glucagon excess stimulates gluconeogenesis, and this polyphagia, that is free fatty acids, also stimulates the liver to generate more and more amount of glucose, that is gluconeogenesis, which leads into hyperglycemia. And this hyperglycemia, which causes some changes in the kidney, degenerative changes in the kidney, which gives rise to more excessive amount of urine get excreted. We call it as polyuria. There is volume depletion. Volume depletion again causes diabetic coma. So this, all the things, they are interrelated. Okay. So this is the morphology of type 2 diabetes mellitus and type 1 diabetes mellitus. In type 2, there is reduction in the number and size of islets of pancreas. There is leukocytic infiltration of the islets, then beta cell degranulation occurs, reduction of the islet cell mass, then amyloid replacement of the islets in type 2 diabetes mellitus. It is related with type 2 diabetes mellitus. Then it also generates hyaline arteriosclerosis, then atherosclerosis, then diabetic microangiopathy, which causes this hemorrhages, cerebral hemorrhages. Okay, then diabetic neuropathy and diabetic nephropathy. Okay, so this is all about of morphology of diabetes mellitus. Okay, now what are the clinical features? Clinical features of diabetes? Yes, anyone? What are the clinical features of diabetes mellitus? Okay, yes. What are the markers of diabetes mellitus? Yes.
Marks of
Yes.
Urination.
Yes. Increased urination, but as polyuria. Okay.
Ma'am, increased thirst.
Yes. Increased thirst. Polydipsia, polyphagia. Okay.
dipsia.
Yeah, polyphagia, but although these both are present, despite of increased appetite, the catabolic effect is very much marked. Catabolism is very much resulting into weight loss. Okay. Okay, resulting into weight loss. Okay, then yes,
Ma'am, fatigue.
Blur vision.
yes,
Blur vision.
blur vision. It is the complication. It comes under the complication. Okay, that is due to glaucoma or glaucoma or cataract. Okay, what are the clinical signs? Common clinical sign of diabetes mellitus. That's on which you can judge that that person may be diabetic.
Ma'am, fatigue.
Fatigueness, yes. Sleepiness, fatigueness because of more amount of
Loss.
present in the blood. So the patient is always drowsy. It is listless. Okay, not active person. Okay, then polyuria is there, polyphagia, polydipsia. Then any other clinical feature?
Weight loss.
Weight loss is there, yes.
Acidosis.
Ketoacidosis, again, it is a complication. Okay, ketoacidosis, it is a complication of diabetes mellitus. It gives rise to nausea, vomiting, respiratory difficulties, okay, increased heart rate.
Ma'am, ketoacidosis is seen in diabetes type 2 also, or only type 1?
Ketoacidosis, it can be seen in, it is a complication in long-term diabetes mellitus. Whenever it, the chronic or whenever the hyperglycemic level is for long period, then this complication can occur. It is common with type 1. Okay, but it may happens in type 2 also.
Okay.
Poor wind. Wound healing.
Yes,
Poor wound healing.
poor wound healing. Yes, because of presence of glucose in the blood. Okay, then yes, any other symptoms, clinical symptoms?
Dragging.
Yes,
Ma'am, hungerness.
yes, hunger increases. That there is,
Polyphagy.
yes, polydipsia, that is increase in thirst. Okay.
Polyphagia. Intake of excess
Yes,
food.
yes. Polydipsia is there, polyphagia is there, polyuria is there. Uh, you remember this polyuria, polyphagia, polydipsia. Okay. Polyphagia, although there is polyphagia, the weight loss is very much huh, in case of type 1 diabetes mellitus also. Okay. For type 2 diabetes mellitus, the age group is little bit middle-aged persons. Okay. But type 1 diabetes mellitus, the age group is little bit less. Okay. In both of this polyuria, polydipsia, polyphagia, it is seen. But the age is with type 2, the age is more older, above 40 years, and frequently they are obese persons. Type 2 diabetes mellitus. Okay. Again, it is depending upon the lifestyle, the eating habits, okay, of that particular person. So this is all about of type 1 and type 2 diabetes mellitus. Okay. If there is any query related with this part. Yes. You want the slides for screenshots? So this type 1 and type 2 diabetes mellitus, the pathophysiology is etiology and pathophysiology is important. Okay. And later on, lastly, morphology. Okay. So I'm going to close this meeting. We will meet again tomorrow at 4 p.m. Okay.